Good morning. It's an honor to be here around a lot of people who have taught me what I know. I consider friends, colleagues, and mentors. My name is Matt Fury. I'm a shoulder elbow sports medicine surgeon down in Louisiana. I was a former HSS fellow. And so my talk is on management biceps labral complex, when to cut, which will be an interesting question. So this all started in 1985. Dr. Andrews wrote this series on 73 throwers who had long-standing shoulder pain. Half of them had mechanical symptoms while throwing. And he took them to arthroscopy, and 83% of the pitchers had superior labral tearing at the time of the scope. And he put an external stim on the biceps and had the biceps contract, and they watched the labrum lift off the glenoid margin and depress the humeral head. So they hypothesized that the tension from the biceps at the follow-through was maybe causing these lesions at the superior labrum. But shortly thereafter, Dr. Snyder wrote this article which described the morphology of various slap tears, gave us our modern classification system, and they hypothesized that a fall onto an outstretched arm would be a mechanism, depending on the arm angle, to create a superior labral tear. But then shortly after that, Burkhardt and Morgan wrote the paper describing the peelback mechanism. So when the arm is brought into abduction, external rotation, the biceps rotates on its anchor at the superior labrum, and this can cause superior labral tears or propagate them posteriorly. And so, this has set off this, phenomenon of the slap tear. Now, I got this slide from a recent talk by Derek Papp, who got it from David Lintner, but it's a great recap on how we didn't know what a slap tear was. Then we started realizing it and seeing it everywhere. There was enthusiasm to fix it, which has since cooled. And now we say, oh, maybe this is adaptive, normal, and we're not going to touch it. So how did we get here? Because there's multiple problems regarding the superior labrum. Problem one is, what is a slap tear? So this is a very interesting study. They took 20 arthroscopic videos, 20 MRIs, sent it to 20 fellowship trained sports medicine surgeons. They gave them different scenarios. They asked them to classify the lesions and what they would recommend for treatment. And then they resent the same the same videos, same MRIs 6 weeks later. And the intra-observer reliability, so same surgeon getting the same videos, 90% moderate to fair reliability. And if you looked at between the observers, so amongst the surgeons, only fair agreement regards to the classification and the treatment recommendation. So why is this? It's because the anatomy of the superior labrum is variable. It's complex. Just a quick Google on the internet shows, these are 4 different pictures. Some of these are obvious, right? There's injected hyperemic synovium. There's that exposure of the non-articular surface, but you can also, in a quick Google, I'm not here. I don't have the probe in this shoulder, but looking at this labrum, I have a hard time seeing that this is a pathologic structure. And so that's part of the problem here. The problem is the anatomy is variable. So over 70% of superior labrum have these type 2, type 3 morphology, where there's a sublabral recess, a natural cleft between the articular cartilage and the attachment of the labrum. And this cleft gets mistaken for pathology and abnormalities. And this is seen histologically as well. The superior labral anatomy is just different from what we're used to seeing in the anterior and posterior labrum, where the labrum normally attaches kind of at or on the glenoid margin. But at the superior labrum, you can see here in this 12 o'clock position, vast majority of patients, there is a cleft and there's a different attachment off of the glenoid face. It provides mobility in this region that's not seen in other parts of the labrum. And just the biceps anatomy alone, this is a classic study in arthroscopy, would show that there's variability on how the biceps attaches to the superior labrum. Some attach primarily posteriorly or posterior dominant. Others have an equal attachment. And all these factors have clouded our ability to understand what's normal, what's adaptive, what's abnormal. So that brings us to problem 2 with superior labral tears. How do we even know that this hurts? Are we just making, something out of nothing, a normal adaptive structure? And I'm not, I won't go that far. I don't believe that. I think that there is pathology here. There have been studies, in particular this one, have demonstrated that there are neurofilaments that are in the biceps insertion, in the superior labrum, extending posteriorly. And in fact, recent study in AJSM showed that the labrum appears to respond to trauma and stress. So on the left side, you have the superior labrum just biopsied after a cuff tear. And then on the right side, there's the superior labrum after a superior labral tear, and there's an increase in neurofilament concentration. So there seems to be a biologic response to trauma. So I believe that there is pain being generated here. It's not all to do about nothing. But I do believe a lot of this is adaptive, and we have to keep a very broad picture a differential diagnosis of causes of anterior shoulder pain in our throwers. Biceps tendonitis, I also think, is probably overblamed in throwers, but we have to consider it. This is all in the spectrum of the internal impingement phenomenon. Subscap strains, whenever you see a subscap strain, you got to think of capsular injuries or micro instability. The pec minor hyperactivity, we'll get into in a second. I'm a big believer. I think that this causes some scapular pathomechanics. Pec major strains we've seen, recently in some of our throwers, thoracic outlet syndrome, and the AC joint can refer anteriorly as well. Now, just touching on the pec minor briefly, this study demonstrates that pec minor hyperactivity, so decrease in the length, causes an increase in anterior scapular tilt and internal rotation. And this tilt is associated in the study with GERD, decreased total arc. There was decreased external rotation in the painful shoulders. And if you just look at the anatomy of the pec minor, you can understand how this can be problematic. And again, this is fringe. This hasn't really been talked about much in the literature, but I believe that this is at play here we have to address. If the pec minor is hyperactive, you can see pulling on the coracoid process, you get this anterior tilt of the glenoid. You have a force that's resisting scapular retraction. And in our throwers, they have to get layback. They're going to get external rotation of their shoulder. So if their scapula is forward flexed and retractions being impeded, they're going to find it somewhere. And I believe that they either find it in the anterior capsule laxity or in the biceps tendons, at the insertion on the superior labrum. So I think this is one thing we have to assess as we are treating these athletes. But the problem with our assessments is, this is really eloquently demonstrated by some of our folks here at HSS, is that range of motion in throwers is a dynamic thing. It changes over the course of the season. This study on professional baseball players showed that as the season progressed, pitchers gained external rotation, they gained total range of motion, and they lost hip range of motion. And so, although a thrower may be well balanced, well compensated at the very beginning of the season, able to handle their range of motion, the question is, as their motion adapts, as they gain motion, do they have the strength, the stability to stabilize the glenohumeral joint as they're moving through these new positions? And I think this is the concept that we have to focus on when it comes to treating a painful shoulder in a throwing athlete. So now that brings us to problem 3. And the problem 3 is, what should we do about this? So first, non-operative management. This is a systematic review. Not historically successful. Return to play 50%, return to prior performance 42%, 5 months return to play. And the risk factors here: longer symptoms, concomitant cuff injuries or other pathologies, were failures, risk factors for failing non-op management. Now, should we just debride the labrum? And this is a classic study by Dr. Alchek, Dr. Warren, Dr. Wick, and they described the results of 10 patients who had superior labral tears underwent debridement, and there was early pain improvement, but 72% of them deteriorated over time. So they recommended, hey, this is not likely a durable option for treating superior labral tears. But why? Why are we at this point where we're realizing that superior labral repairs are doing well historically? And it's for multiple reasons. Number one, there's dense extracellular matrix at the superior labrum. There is lower vascularity. There are lower progenitor cells. The environment for healing is suboptimal compared to other parts of the labrum, as you can see in this study. And then whenever we talk about biology and preserving biology, we need to understand the blood supply. In this study, which injected India ink in the thoracoacromial artery, showed that the blood supply to the proximal biceps comes in from the anterior dorsal soft tissue. So if you place an anchor within 3 millimeters anterior to the biceps tendon, you may be impeding the blood supply to the biceps attachment, but posterior anchors were not disruptive. And this anchor position has been studied, and this is a big controversy in treating these. This study by Dr. McCulloch showed that they created a slap tear. They did a 3 anchor repair, and the 3 anchor repair had a 2-degree restriction external rotation. So then they removed the anterior anchor, and that restored their motion. So the conclusion after the study was that in throwers who may be very sensitive to these small changes in range of motion, and posterior repair is likely advisable in order to avoid motion restriction. And this has been seen clinically in some studies. This is one comparing anterior posterior repairs versus just posterior only repairs. And the posterior only repairs had 60 degrees of external rotation versus 40 degrees. Now, this is ER at the side, so it's not the 90-90 position. It probably doesn't totally translate, but it's a indicator that clinically we see some stiffness. But the relationship with stiffness and slap repairs, like in the rotator cuff, is complicated. Dr. Warren talks about stiff cuffs end up being the ones that tend to heal. Well, this study shows that, slap repairs, 27% of patients had stiffness at the 6-week mark, but the patients who were stiff at the long-term follow-up had less difficulty with their overhead activities. Now, when we're talking about stiffness and trying to preserve motion, especially in our throwers, this technical article by Dr. Dines, Dr. Elitrosh, they described a way to preserve the superior labral anatomy by using knotless horizontal mattress fixation. You can fix the superior labrum just off of the glenoid margin to where you can restore that sublabral cleft and maybe some preserve mobility while providing some stability and not over constraining the superior labrum. So this is my kind of preferred method of fixation as well. But the problem with the superior labral tears is that they're rarely isolated. There's often other lesions, and these lesions matter. The study out of Curlin Job, 23 athletes underwent slap repairs, 35% had partial thickness cuff tears. And if you look at how they did, if they didn't have a cuff tear, 80% returned to prior level. But if they had a partial thickness cuff tear, 12%. So very sobering. And so then should we fix everything? That was the question that Dr. Field, Dr. Savoy tried to investigate with this study, where they did slap repair, posterior capsular release, and repair the infraspinatus, and only 35% returned to their same level of performance. So that does not seem to be the proper approach either. So because of these sobering results with the slap repair, we had renewed interest in biceps tenodesis. We treat a lot of our non-throwers like this for superior labral pathology. Can we do it in throwing athletes? And Dr. Romeo described their results, 16 overhead athletes with an 81% return to their prior level. Now, systematic reviews haven't been quite as successful, about 70% overall in professional athletes, 60%. And if you look at the MLB hits database, it's small numbers. This is just 14 throwers, but 86% return to play, but only 50% at the same or higher level. So should we just do both? Should we repair the superior labrum and the biceps? This study showed that those patients tended to do worse based off of their ASCS or VAS scores, but I think that's confounded by the fact that they were worse off preoperatively, and they were a higher percentage of overhead athletes. So, is there a difference biomechanically in pitchers trying to get back? Very interesting study by Pete Chalmers and the folks at Rush. They had 6 patients with slap repairs, 5 biceps tenodesis, 7 control, and they found that there were differences. Altered trunk rotation, knee flexion angles in the slap repairs, but the biceps tenodesis cohort, they had a change in their duration of the cocking phase. So, an interesting study. I don't think it necessarily slams the book either way, but shows that our pitchers after shoulder surgery are just different in their mechanics. So some people have described using injections to try and help us decide biceps, labrum, how we're going to treat. And I think there are important nuances we have to keep in mind. This study, anatomically, the glenohumeral capsule is confluent with the biceps sheath. So in this study, they injected 5 milliliters into the biceps sheath, and all of the specimens had intra-articular extravasation. And this has been seen clinically too. In this study, they injected 50 patients, 5 milliliters in the sheath, immediately sent them to X-ray. 60% of them had contrast in the glenohumeral joint. So the important concept here, which has been shown by Kenny and a lot of our folks at HSS, and this is a guiding article for me, you have to use low volume. So if 2 cc's in the biceps sheath, only 2 out of 7 communicated with the glenohumeral joint, and there was no extra communication with simulated motion. So move their arm around, throw, it didn't seem to go into the joint. But if you injected higher volumes, or if you injected into the glenohumeral joint itself, those flowed back and forth between the joint and the sheath. So the takeaway is, if you're trying to do a diagnostic biceps injection, low volume has got to be your key. So, just to back to that video study, this is how the players were treated. But this is the problem. This isn't really data. We can't decide what's a slap tear. We can't decide how to treat the slap tear. We can't decide how to do the surgery that we think we should do to treat it. So it's all really just clear as mud. So with that, this is my approach in 2024. And this is neither evidence-based nor eminence-based, as I can't claim to know what I'm doing here, but I just care a lot about this topic. And so in my mind, if I think a thrower has a symptomatic superior labral or biceps tear, this is a physical therapy. Physical therapy is my line of treatment here, and it's focused on motion, kinetic chain assessment, assess the posterior capsule, their anterior stability, pec minor stretching, make sure they can get their scapula in proper positions and their rhythm is appropriate. And then in their arc of motion, is their cuff strong? Do they have stability? And continuing to evaluate their motion as they progress through a program, because their motion may change. If they are failing physical therapy, then I go for a glenohumeral joint injection and they go back into therapy again with the same concepts. And if they fail that and we're kind of moving in the direction of we need some diagnostic help to plan a treatment, 2 milliliters diagnostic biceps sheath injection. If they have a great response to that, then we discussed doing a subpectoral biceps tenodesis. Otherwise, if we're opting for superior labral surgery, it's either going to be debridement repair and then in my hands, posterior anchors with knotless configuration, try to preserve that mobility and not interrupt the blood supply. So thank you. Really honored to be here. Great learning opportunity. Thanks for the opportunity, and please reach out with any questions.